Thank you very much, President, for your kind introduction. Just a correction, my name is Dr. Jayantha Wijerupa. Most of the people usually get it wrong. So it's about cinnamon peel syndrome and few suggestions from the peripheries. And again, I would like to thank Ceylon College of Physicians for giving us this opportunity to present and to have the learning experience again. So key areas of focus of my lecture will be not only cinnamon peel syndrome, I have some suggestions. So there's retrospective analysis of acute coronary syndrome data in Kamburupitiya with some suggestion to policymakers. Then cinnamon peel syndrome, and third one will be the beyond the hospital boundary about a new organization with innovative concepts for survival in current economic crisis. If time permits, I will just touch upon DNA, CPR, and prognosis score, especially for the oncology people. So, especially they are coming without any cards, so we are having a lot of difficulties in managing it at T2 in the peripheries. And BLS, are we doing enough to familiarize with the public? I hope there will be no time enough for 4 and 5. So, starting from case number 1, 57-year-old male presented to chest pain 1 hour earlier to a rural hospital, and after ECG, they have diagnosed ECG and STEMI. Doctor happened to be a MBBS graduate who's working in the rural hospital and treated with aspirin, statin, propofol. And unfortunately, at that time, there's no ambulance available there. And they had to contact our hospital and get the ambulance. So additional 1.5 hours passed, even after diagnosing anti-stem. And came to our hospital, then inosoparing antigen given, and ECG, a 90-minute ECG shows 50% reduction in the ST elevation. Later on, while in the ward, we did take over, it shows 45% of ejection fraction. And unfortunately, he couldn't have the palm invasive therapy while in the ward. The key points I want to highlight is additional 1.5 hours passed after having contact with the first medical contact being a doctor. And the other point is palm invasive therapy, we couldn't get it done. So I have some suggestions for that. And about the study we have done, so study was to study 2 cases with acute coronary syndrome presenting to base hospital Kamburupitiya, and the specific objectives were to evaluate the types of acute coronary cases present to Kamburupitiya and to analyze the final therapeutic modality used in STEMI patients and to evaluate the delay from onset of symptom to intervention in our patients. So here you can see during first quarter of this year, 165 patients we have treated for acute coronary syndrome. Out of that, 35 was STEMI, 106 unstable angina. Particularly about STEMI patients, so the therapeutic modalities we can achieve only two patients we could get for PCI. The percentage was 5%, and majority was treated with thrombolysis, and inospiraling given for other patients who was most of the time delay, more than 12 hour delay on admission. And while preparing lecture, actually, I came across this circular. That's again a problem with our circulars. There should be some ticking procedure or something whenever there's a new circular which is important, released by the ministry. So in the circular also, it is mentioned that there should be pump invasive therapy within 2 to 48 hours after the thrombolysis, even during economic crisis. So now some people think now we are out of economic crisis, so it should be better than we should be able to do more than that in that case. So 94% of STEMI patients in Kamburupitiya, they didn't have primary PCI, rescue PCI, or pharmacoinvasive treatment. This is about the delay on admission. So you can see 75% of the patient of acute coronary syndrome delayed more than 3 hours for admissions due to various reasons. That was not my objective at that time to assess what are the causes. About the STEMI patients, pre-hospital delay for STEMI patients, again, about 60% of patients has taken more than 3 hours for admissions. And out of that, about 9 out of these 21 patients, the delay is because of non-direct admission, means they have transferred from a rural hospital. I will emphasize the importance of that later. So this is door to needle time about some quality of our hospital. So 30% of our patients achieve 30 minutes mark, which should be the ideal. And we are at the moment we are looking into the causes whether we can correct it. This slide is a very important slide and very famous slide also. So pre-hospital delay, how it will affect the mortality reduction for STEMI patients. So you can see after 3 hours, the mortality reduction come below 20%. From 100%, 90 to 90, above 80 to 20%, it goes down. If you take more than 3 hours, that's it. So this kind of similar trials has been done earlier, so in 2015 in Peradeniya. So what I want to highlight is this delay was there even in Peradeniya. 16.9% patients in 30 minutes thrombolysis was given. At that time also, none of the patients underwent PCI. And even so, what they have done more than us is they have follow up this patient for 1 year. Even after the follow up after 1 year, coronary intervention, only 7.3% had coronary intervention after 1 year. So there's again the important article published in Heart Journal, the NHSL availability of PCI. So they have mentioned the quality assessment of PCI and acute myocardial infarction management in NHSL. So they have done 60% of the patients. They have done more than 50%. They have done PCI, around 60% PCI plus thrombosis. And the lowest compliance observed in the organization structure and the process of care, which I think if we have a better discussion, can intervene and change. This is now, usually we like to compare with Kerala because it's most of the time quite similar to our characteristics. So this is comparing PCI availability in care, state of care. There you can see about 70% of the population, they have PCI is available within 0.5 hours for 70% of the patients in care. And thrombolysis plus PCI about 90%. It doesn't mean that 90% of patient having the opportunity to get the PCI, but the opportunity is there. So this is the reason, because they have thrombolysis capable hospitals, 221 capable hospitals in private sector, and public sector around 37. PCI capable, 93 private hospital in Kerala. So you can see what kind of improvement we should have for PCI. and 10 public sector, so same as like in our country. This is the comparison. So land area wise, we are bigger. The population wise, Kerala is bigger. So we need major improvements, even in private sector. So this is these are the hospitals in Sri Lanka. So you can see or base hospital B. Above that, we can give thrombolysis. So around 120 thrombolysis capable centers we have. PCI probably is around 10 or around 10. Here I want to highlight that now there are type A division hospitals, around 78 division hospitals. So if we can make thrombolysis available in those hospitals with the supervision of the nearby consultant, we can easily increase up to 200 thrombolysis capable centers in Sri Lanka. So there has been probably there has been discussion in various colleges how to increase the quality of care in acute myocardial infarction in our country. So these are the articles published about that, and they have suggested, College of Cardiology, they have suggested about this thing. So this is called wagon wheel method. Here they have mentioned about the level 1, level 2, and level 3, 3 levels of care. In level 1, that is primary PCI capable center. So straight all the admission, if possible, go for the primary PCI. The level 2, within 2 hours, if patient can be transferred from other hospitals, those other hospitals should transfer this patient to PCI capable center for primary PCI. Level 3, that is beyond 2 hours. So it's for pharmacokinesis after thrombolysis. This is the wagon wheel method for PCI. So my suggestion to improve quality. So it's obvious that more PCI capable centers should be here in our country, widespread PCI capable centers. And while having the long-term wagon wheel, they have mentioned about this island-wide data registry, but I'm quite sure now it's not active at the moment in Southern Province, but probably maybe in Western Province. I'm not sure about it. But while we are going for the long-term things, short-term solution should be given. For example, it's better to give a permanent on-call mobile number pager to on-call cardiologist or someone who's appointing for instead of him to hand over patients from peripheral use. And it's better to have a one number for a PCI center, and then they can change it when on call is shuffling. And it's better to have 24/7 PCI beds in capable centers. So in that case, there should be 7 interventional cardiologists in a center. So I believe rather than putting intervention cardiologists in a very remote area where just echo machine is available, it's better to put in a PCI capable center, put in a roster, and manage to get the best out of the cardiologists. That should be the way. And it's better to give some incentives for not only for the cardiologists, for the whole staff. Whenever they have performed primary PCI, whenever they perform rescue PCI, whenever they perform pumpkin issue, there should be some incentives. Or else, no, other countries' consultant salary is not the same. So maybe salary composite score given to consider, and the salary scale should be restructured. I'm not an expert on that, but that should be done. That will boost our PCI, I think. And about the pre-hospital and primary hospital level thrombolysis. Pre-hospital, it's okay in some countries. It's done. The paramedical staff, they are giving thrombolysis. So what about us? So according to our study, there was actually more than 60% delay for STEMI patients with non-directed admissions. That means going to rural hospital and taking vital hours to transport. So what I'm suggesting, that PCI wagon wheels already has been introduced. So this is thrombolysis wagon wheel. We can go for. So in guidelines also it's mentioned as first medical contact, not first medical doctor. So here we have first medical doctors. So so I think the thrombolysis should be available even in at least in peripheral type A peripheral hospitals. Then tenant-based vial at least one in nearby pharmacy. And I got to know, so it was around 80,000 before economic crisis. Now it's around 180,000 vial. But I feel even a common man, if he realize the gravity of the delay, they will buy it. Fraction of them, they will buy it. Then about this pharmacokinetic cost, if you give tenant to place and send him for PCI, and if you compare it with just primary PCI, you can imagine the difference. So I believe as far as possible, we need to give incentive for the primary PCI. And this pharmacokinetic will cost more. So it's rented for a while, I said around 180,000. Even half of that can be taken out for as an incentive for the staff who doing PCI. This is the thrombolysis wagon we propose. Okay. Hopefully you can ask question at the end. So I'm moving to the other topic, cinema policy. So background story here, cinema process is a very major industry in Kamburupitiya. And during cinema filling session, usually there are a lot of patients come with tennis elbow-like syndrome, frozen shoulder-like symptoms, and lower backache. So I thought of looking into these matters. Then I came across some other clinical manifestations associated with these workers. We talk about the cinnamon. So pure cinnamon is the world largest producer is our country, and not cassia cinnamon. It's pure cinnamon. And there are some evidence coming up. The cinnamon can be used in type 2 diabetes and hypertension and hyperlipidemia with beneficial effects. And our market will expand further. So there is very high demand for this industry, but it's short of supply. We cannot supply according to the demand. One is the shortage of these workers, and this very artistic job and need skills. And that's why the shortage of workers and need of specific tools, which will give rise to specific clinical features and specific occupation-related hazards. This is again about some, because people are interested in these facts also, I just put this one. So this is the document where it's mentioned about our written evidence we can find in this book, which has been written by merchant in Iran. Book has been published as Wonders of India, written evidence of our Ceylon cinema. Why I am interested, so you can see in Golden Matra, the cultivation and manufacturing industrial process is very common in our area, Golden Matra. So this is a process, this harvesting, transport to the peeling, removing, not scraping with a tool called cocatta or southwood. Then rubbing with a brass rod, peeling with a small knife, then making peels, drying under shades, pressing peels, trimming with the scissor, drying under shade again, and making bundles of cinnamon called bales, which can be transported through ships. These are the special equipments. It goes through some videos. You can see the way they are doing it. This is how they scraping with southwood. This is called southwood. The equipment called southwood. And you can see it's a repetitive task which give rise to lateral epicondylis like picture. This is how they rubbing with the brass rod, which is again a repetitive task, and they have to hold the cinnamon stick with the other hand, which will give rise to the contralateral pain in the other shoulder, contralateral frozen shoulder like picture. This is again. This is the way they are peeling with the knife, and when they remove this bark, the edges are sharp. So then it touches with the thumb, which will give rise to cuts and abrasions. This is how some of them keep their sticks between the fingers. So there will be callus formation between toes. This is again the method of rubbing. I have already shown that, so we'll skip to the other side. So this is the usual position they are working. So traditional cinemas, this is the way they are working. So they are sitting like this for hours, 8 to 12 hours. Leaning forward, so at the end of the day, evening, they have low backache with stiffness. This is the rubbing procedure, again ipsilateral tennis elbow and frozen shoulder and the contralateral shoulder pain. So that's it. So these are the callosities which can because they are using specific tools. When they are using brass bar, they have these callosities, especially in a linear pattern along the distal skin crease. The farmers, they have usually the calluses like here, but here the calluses in around skin crease, distal skin crease. Here they can have again a callus formation due to knife in the hypothena eminence. And they are keeping the one leg extended like this and the one leg crossed. So, which will give rise to callus formation in the lateral aspect of the foot. And here this the callus formation between legs, and they have callus formation and skin thickening over the heel of the extended foot. And sometimes they are using some modifications, some equipment like this for rubbing. Instead of the brass bar, they are using that. It's around 20,000 rupees. And if you use that, you can see here he doesn't have the callus formation over the distal skin crease. And here they are using rubber sheath to protect from the cuts to index finger. So, because as they are wearing the sheath for a long time, they develop this soft skin. Soft skin over the index finger. You can see this soft skin, straight away it becomes thick. For the trimming purpose, they are using scissor, pair of scissor. So it will give rise to again the callus formation after prolonged use. So in short, this is the Cinnamon syndrome in short. So there are dermatological and rheumatological manifestation, dermatological hand. So that kind of callus and abrasions, cuts. I have showed you smooth distal part of the index finger and discoloration of the palms due to staining. And the feet, the callus over the heel, callus over the lateral side of the foot, and the upper limb, rheumatological wise, wrist pain. Some people have carpal tunnel syndrome, tennis elbow, and frozen shoulder, the ipsilateral contralateral side of frozen shoulders, and sometimes buttock and thigh pain also with cramping pains, especially at the end of the day. So that is I would like to introduce as Cinnamon-Wheeler's syndrome. Same way, like you can discuss about T-Plucker syndrome and coconut-Plucker syndrome, but this amount of clinical features will not be there. So these are the modifications introduced by the Cinnamon Research Center. This is again a modification for rubbing machine, and these are the machines developed by University of Moratuwa even, but these are only prototypes. They are not produced in industrial level. Again, the things introduced, this is called cinnamon table. So you can see there are some gadgets which can bear the weight of the stick, which will prevent from this the contralateral frozen shoulder from appearing. Then this is called modified cinnamon table. You can see they are sit in a straight manner, so lower back pain will not be an issue. So then I will touch upon these what are the small the short cases. 74-year-old male COPD recurrent exacerbations has to admitted several times, and he has his son, who is a manual worker, who's earning about 2,500 per day, has to stay with him. Problem. And 50-year-old male came with an ostomy, exercise done, had to do an angiogram, waiting in the angiogram list. No insurance. So that kind of clinical scenario is abundant in our hospital, in our wards. So anything we can do, is especially during this economic crisis, anything we can do. So that is beyond the hospital boundary. Being Homo sapiens, when there are crises, when there are problems, we used to get together as working as a group. That's why we have survived. So, can we survive as a group in this economic crisis? Uh, this is a community organization we have established in our area. It's an organization of social entrepreneurship. So all for one for all will be the concept, and so we try to establish a fund and strengthen it by our effort of the members. These are just a lot of photos. So this is the initiation of our society, and so expanding into the other organization and institutions. This is our membership card. These are the these are the projects we carried out to promote our organization and to promote the well-being of the society. And these are some of the innovative projects we carried out, especially during COVID season. Most of our people engaged in the gardening, so plant exchange program and distribution program at the hospital. And these are the fundraising initiatives, green bag with some specifications to carry vegetables. Basic life support for community projects and to expand our membership. Few other fundraising events, film, movies, and this is the most important one. I say you, most of us, you have seen charity shops in other countries. So we have done it, even though it's not a permanent shop. We have done charity fairs by selling reusable items. All right. So because of the time, I'm so going. Because as I time pass, I will just click on these things. So we have some the scholarship programs also. We think it as investment program. So we are coordinating with the foreign donors who like to intervene for our crisis. And okay. These are the future for our society. So expansion of various programs and so this slide I would need to tell these are donation from the self-earned funds for the members in need whenever they face difficulties. Then if I ask, I can tell about other innovative things. This is called Project 10%. In the discussion, if anybody asks, I will explain it. So that's it for my presentation. So I think probably the question time may be later, or I'm not sure.
Thank you very much, Dr. Wijerupa. We'll be discussing these things afterwards. I think in the interest of time. But your suggestions are very important. I think we should look at them and have a discussion once we finish this.